dear students. I'm Dr. Pratyusha. In the previous video, we have learnt about the anatomy of external nose. Now in this video, let us discuss about the disorders of external nose. As you all know, external nose is a pyramidal structure that consists of bone in the upper 1/3 and cartilage in the lower 2/3. And also it is lined by skin. I hope you all remember the anatomy properly. Okay. Now let's delve into the disorders. The disorders of external nose could affect the skin, cartilage as well as the bony framework. We can learn them under various subheadings. To begin with, let us first discuss about the deformities of external nose. Deformities of external nose. Now these deformities could be either congenital or acquired. They could be present by birth or they can occur later on in life. Why would they occur later on in life? The most common reason is trauma. After a trauma, either because of dislocation, repeat, after a trauma, either because of dislocation or post-traumatic malunion or various other factors, a deformity can occur in the external nose. After a trauma, it could be a malunion or a dislocation that disturbs the normal anatomy of external nose, giving rise to a deformed appearance. Now, deformities of the external nose are a very big concern for the patient, usually in terms of cosmetic appearance, because any deformity of the nose will be very prominently seen on the face of the person. So, patients are usually concerned about the appearance of it. And the second problem that can occur is a functional one. A deformed nose could give rise to nasal obstruction, leading to difficulty in breathing. That is the second problem. Usually patients present with these two complaints. Okay. So let us learn about the various deformities. In deformities, I can again segregate them under two categories. One is the midline disorders and second is the lateral wall disorders. Okay. First, let's learn about the midline disorders. Among midline disorders, the first one is a saddle nose. Saddle nose is a small depression in the nasal bridge. Okay. Why will a saddle nose occur? What is the etiology? Most common reason, as we have already discussed, is trauma. Now this trauma could be some external injury or an accident, or it could also be iatrogenic during a nasal septal surgery, especially during submucosal resection. Sometimes too much of the septum is removed and that can later on lead to saddle nose. Trauma, nasal surgeries, and some infections affecting the nose, granulomatous disorders especially, such as syphilis, leprosy, tuberculosis, they can cause invasion and erosion of the nasal septum and other surrounding structures, leading to a depression in the external nose. Okay. Infections such as syphilis, leprosy and tuberculosis. Apart from that, a septal hematoma or a septal abscess can also give rise to saddle nose. Now please remember, any deviation or disturbance in the septum will usually be reflected in the external nose. Okay, so any septal deviations or dislocations usually result in an external nose deformity also. Please remember this. So how do we treat saddle nose? What is the treatment? I told you there is a depression. So what we have to do? We have to do an augmentation rhinoplasty. Augmentation rhinoplasty is the treatment. Depending upon the size of the defect, a small piece of cartilage from the nose itself or the ear lobule or elsewhere in the body will be taken and replaced in that area to cover the defect and the depression. So this is about saddle nose. Let's move on to the next one, and that is hump nose, the exact opposite. What is hump nose? There is excess of bone or cartilage. It appears like a elevation, like a swelling. Okay, that is hump nose. Now with hump nose, there is usually only a cosmetic concern. There is no functional abnormality. A hump nose will not produce any difficulty in breathing. Okay, how do we treat a hump nose? Treatment is by reduction rhinoplasty here. In saddle nose, it was augmentation rhinoplasty, and here it is reduction rhinoplasty. Why reduction? Because there is excess cartilage and that has to be removed. Okay. Next in our list is a tip deformity. In tip deformity, we have various subcategories. All of them together are called as tip deformities. The tip of the nose could either be bullous, it could be narrow, or there could be a pinched tip or a bifid tip, under projection, over projection. Sometimes the tip comes way below. Yes, a rotated tip. Like that, various type of tip deformities are present. Now the catch with tip deformities are the plastic surgery to repair them is quite difficult. Even for an experienced surgeon, tip deformities have to be dealt with some special care. Okay, they are difficult to correct and there are various types. With this, I complete the midline deformities. And next we have lateral nasal deformities. When I say lateral nasal deformities, please do not think they involve the lateral wall. They could involve the septum and the medial wall only, but they deviate from the center. That's it. Now, saddle nose, hip nose and all, they are absolutely in the midline. There is no deviation to either side. Okay. If it is deviated, then we call them lateral nasal deformities. I hope the distinction is clear to you. Okay. Under this, the various subtypes are, first one is crooked nose. Now, these are usually due to an underlying septal deformity that is being reflected in the external nose. Okay. Crooked nose means the dorsum of the nose is crooked. It is C-shaped or S-shaped. It is towards one side, either to the left or to the right. That is why it's called lateral. If it is towards the right, we call it right crooked, and if it is towards the left, we call it left lateral, left crooked deformity. Okay. Usually C-shaped or S-shaped deformity is seen. And what is the treatment for this? Lateral and medial osteotomy has to be performed. Lateral and medial osteotomy. After doing osteotomy, we have to release the septal cartilage from the upper lateral cartilage by intercartilaginous incision. Now, I hope the anatomy is fresh in your mind. We have upper lateral cartilages. that are attached to the septal cartilage. There we have to give an intercartilaginous incision. I told you it is actually a septal deformity that is being reflected in the external nose. So the septal cartilage has to be released and repositioned in its proper place. This is the treatment of crooked nose. Then next we have a deviated nose. In the deviated nose, what we find is the dorsum is deviated away from the midline. Now you might ask, in crooked nose also that is what is happening. No. Crooked nose will look something like this towards one side. This is the nose. If this is the external nose, crooked nose is towards one side like this. But a deviated nose is a straight line that is deviated to one side. It's not curved, it's a straight line, but it has gone to one side. Is that clear? Okay. How do we treat this? Again, septoplasty, because problem is actually with the septum. Apart from these two, there is another condition called as alar depression. The alae of the nose are depressed. That also comes under lateral nasal deformity, and for that also, in case if it is causing a functional problem, a reconstructive surgery can be performed. So these are about various deformities, and then after midline and lateral nasal deformity, we have a third category, and that is stenosis and atresia of nares. Stenosis and atresia of nares. I am talking about the external nares here, okay, because we are still discussing about external nose. Choanal atresia is a different condition, that is the internal choanae are closed, okay. Here in stenosis and atresia, you have to remember that a web is formed. Web formation occurs. Now, why does web formation occur? Mostly after a trauma. Post-traumatic web formation occurs during the healing process. A web is formed that closes the external nares. Or sometimes after the surgery of the nasal tip or vestibule also, a web can occur. Web formation either post-traumatic or post-surgical. Which surgery? Surgery of the tip or vestibule. Sometimes even destructive inflammatory lesions of the nose will give rise to web formation, or they can cause closure. Stenosis can occur. And very rarely congenital atresia of the nares can also occur. Proper recanalization does not happen, and that leads to congenital atresia, but it is quite rare. This will lead to nasal obstruction, absolutely. So it has to be treated by a reconstructive plastic surgery. Now, treatment of all deformities, in one word if I have to tell, it is reconstructive plastic surgery. What you have to specifically remember is, for saddle nose, it is augmentation rhinoplasty, and for a hump nose, it is reduction rhinoplasty. It's not something difficult. If you have the picture of saddle nose or hump nose in your mind, you can automatically predict what will be the treatment. So with this, I complete all the deformities. Next, let us learn about the second category of disorders, and they are inflammatory disorders. Inflammatory disorders of external nose as well as vestibule, let us discuss together, okay. So first among these is vestibulitis. What is vestibulitis? It is diffuse dermatitis Where? In the vestibular area. It's as simple as that. It is diffuse dermatitis in vestibular area. What is the etiology? Why will this inflammation occur? First is, if there is a persistent infected nasal discharge that is leading to irritation and maceration of the skin of the vestibule, it will lead to vestibulitis. Is that clear? And that's quite predictable, right? When a person is constantly having running nose, that too with purulent secretions, infected secretions, it will lead to irritation in the vestibular area. Persistent infected nasal discharge. Leading to irritation and maceration of vestibular skin. Second possible cause is nose picking. That is also very common, especially among children. Nose picking. Either the fingernail trauma can occur, or sometimes they could even put some foreign objects into the nose. They all can cause vestibulitis. And third reason is frequent cleaning of the nasal discharge with a handkerchief. See, too much cleaning, applying too much pressure can also upset that sensitive area. It can cause maceration of the skin. And secondly, when you use a handkerchief, it will cause reinfection. The same hanky is used over and over again, and all the secretions and infective organisms are present on the handkerchief, and repeated usage will lead to repeated infections as well as maceration of the skin. So it is advisable that you use disposable tissue papers or some soft material to clean and wipe the nose. Wet mops have to be used. Okay. They will prevent this skin maceration as well as reinfection because they are disposed of. These are some of the causes. And you should also remember what is the causative organism. Guess what is the causative organism? Our all-time favorite, Staphylococcus aureus. Staph aureus is one of the favorite organism of students because anytime you do not know what is the causative organism, you can just always blindly say Staph aureus, most of the situations. But for doctors, it's a deadly organism because it's very resistant to treatment and it's something that we dread. Okay, that is the transition between student life versus practice. Okay, all right. If we look at clinical features, what can you expect? Now, vestibulitis can occur either in the acute form as well as in the chronic form. Okay, first let us look at the acute presentation. In acute presentation, the patient will experience itching and irritation of the nose. There will be itching and irritation of nose as well as pain in that area. On examination, what you will find is there will be redness. All signs of inflammation will be there. Tenderness, swelling, Okay, and sometimes crusts and scales can also be seen. Crusts and scales, even excoriation of the skin is a common finding. Because of all the nasal discharge and everything, maceration of skin, excoriation of skin will occur. And if at all, if it is a chronic case. In a chronic case, the most important cardinal feature is there is induration of the vestibular skin. Please remember, what will you find? Induration of vestibular skin. And of course, there will be painful fissures. Painful fissures and crusting will again be seen. This is the clinical presentation. Now, how do we treat this? Treatment of vestibulitis. 1, you have to clean the nasal vestibule. For all the crusts and scales, all of that has to be removed. How will you clean? Not like the patient taking a handkerchief, right? We will use a cotton swab that is soaked in hydrogen peroxide. Even silver nitrate is used. And then after cleaning, antibiotic as well as steroid ointments have to be used. Steroid ointment will prevent further worsening, further inflammation, and antibiotic, of course, because it's an infective condition, we have to use. Some Staph aureus specific antibiotics have to be used. And most importantly, you have to treat the cause. Now, why is the patient having repeated nasal discharge that has so much so led to excoriation of the skin there, that has led to vestibulitis? You have to find out and you have to treat that. Maybe the patient is a case of syphilis or leprosy or some reason that is going on causing nasal discharge. That is most important. So, with this, I complete vestibulitis. Let us look into the next condition, and that is furunculosis. What is furunculosis? Acute infection of the hair follicle. Where? In the vestibular area. Acute infection of hair follicle in the vestibular area. Now, why does this occur? 1, again the common cause, trauma from nose picking. Plucking of the nasal vibrissae can also lead to furunculosis. Plucking of nasal vibrissae. Now, the patient could themselves pluck it, or sometimes, very rarely, during an ENT examination, while we put in instruments, these vibrissae can get trapped in the instrument, and when we are withdrawing the instrument, they can be plucked out. It happens very rarely. Usually, doctors are mindful about this condition, so they see that vibrissae are not trapped. But in that situation also, later on, it can get complicated into a furunculosis. And what is the causative organism? Again, Staph aureus. Most common causative organism is Staphylococcus aureus. And you have to remember that there is a predisposing factor here. Usually, furunculosis does not occur in everybody. It occurs in people who are immunocompromised. In immunocompromised states, either long-term steroid usage, or the patient is an uncontrolled case of diabetes mellitus, or AIDS positive case, or post-transplant case when he's under immunosuppression because of the immunosuppressive drugs. Usually, immunodeficient states, when a person is in immunodeficient state, all these infections tend to occur. Next, let us look into the clinical features. Furunculosis is extremely painful, okay? Please remember that. Upon examination, it looks just like a small, sometimes it could be as small as our facial acne, just very small. Sometimes, of course, it could be quite big, but disproportionate to its appearance, it will be painful. Very, very painful, okay? That's the reason patients come to the doctor, because it is extremely painful. And when you examine, of course, the other signs of inflammation will be present, such as redness, tenderness. As I told you, it's very painful. Even when examining, the patient will complain of tenderness. And swelling will be there. So, how do we treat this? Now, the major complaint of the patient is pain, right? So, to relieve pain, we can give warm compression, advise the patient to take warm compression, and analgesics can be prescribed for pain relief. Because it's an infective condition, antibiotics will of course be given. Here also staphylococcus specific antibiotics. See, you can use cloxacillin or cefaclor, anything that works on Staphylococcus aureus. Now, if it is a really big furuncle and if it is fluctuation positive and if it is well localized, then you can also plan an incision and drainage depending upon the size. Okay. Now, more than all these things, more than the treatment that you have to give, you have to remember what you should not do. Something that should never ever be done by you or the patient also is trying to squeeze the furuncle. Because it appears like a purulent structure, sometimes patient feels like squeezing it and letting all the pus out, but that should never ever be done. Why? Because it comes under the dangerous area of face and that could complicate to cavernous sinus thrombosis and it can become life-threatening for the patient. Imagine somebody dying of furuncle in the nose. Why will that happen? Because of pinching the furuncle and all the infection could go because of the valvelessness of the facial veins. The infection can directly go into cavernous sinus thrombosis. Repeat, the infection can directly go into cavernous sinus and cause cavernous sinus thrombosis. What is the complication? Cavernous sinus thrombosis. It can sometimes complicate into a septal abscess also. If it's arising from the medial wall, it can later become a septal abscess. So this is all about furunculosis. Next in our list, we have cellulitis. What is cellulitis? Nasal skin infection. Okay, it is nasal skin infection caused by Staphylococcus or Streptococcus. Cellulitis, as you know, can occur anywhere in the body. It can occur in the nose also. So, when the nose is affected by cellulitis, it will become red, swollen and it is very tender. How should we treat it? By antibacterials and analgesics. Now, there is nothing very specific about cellulitis of the nose. What you have to remember is, just like how cellulitis occurs elsewhere in the body, it occurs in the nose also. And everything is the same. There will be redness, there will be pain and tenderness. okay, and of course swelling. And how will you treat it? What is the treatment? Again same, antibacterials and analgesics. The last condition under inflammatory disorders is erysipelas. Okay, what are erysipelas? Repeat. What are erysipelas? It is acute spreading cellulitis of the face. That's again caused by streptococcal dermatitis of the vestibule. So it begins as a small cellulitis in the vestibule and then it acutely spreads onto the face. That is erysipelas. Let me write that down for you. Acute spreading cellulitis of the face caused by streptococcal dermatitis of nasal vestibule. What will be the clinical features? Now, erysipelas is much more serious than cellulitis. I hope you have understood that. Right? So, you will see fever. There will be lymphadenopathy. And when you examine the area, it's all red, swollen. The entire vestibular skin appears red and swollen. What you have to remember about erysipelas is the margins are sharply defined. Okay, sharply defined margins. And this will spread outwards from the vestibular area. It will spread outwards into the face and it can come up to the eyelids. Into the face and eyelids. And the complication with erysipelas is this can also result in cavernous sinus thrombosis. You will learn in detail about cavernous sinus thrombosis while learning about the complications of sinusitis. Okay? And how do we treat this condition? Very simple. Again, because it's an infective condition, we will have to prescribe antibiotic. Penicillin is the drug of choice. Analgesics will be given to relieve pain. And anti-inflammatory drugs like serratiopeptidase can be given. So this is about erysipelas. Now with this I complete all the inflammatory disorders also. Now let us look into the last category of external nose disorders and they are tumors, neoplastic disorders. Any list gets completed by finally discussing neoplastic disorders. So, neoplastic disorders of external nose can be studied under three headings: congenital, benign and malignant. Okay. So, first let's discuss about the congenital ones. Under congenital tumors, let us first discuss about a dermoid cyst. Now, dermoid cyst could be a simple dermoid. When I say simple dermoid, what I mean is it will occur like a midline swelling. It's in front of the nasal bones. That is most important, okay? A simple dermoid what you must remember is lies in front of the nasal bones. Okay, so it will just occur like a midline swelling, external swelling, and there is no external opening. Fine, that is a dermoid, a simple dermoid. Next category we have a dermoid with a sinus. Dermoid with a sinus will communicate with the external environment. These are seen in infants and children. On the external surface, on examination, you can see a pit or a sinus in the midline, on the dorsum of the nose, you can see. Now this, you can either see it as a pit or a sinus, or even a small hair could be protruding through that opening. So a hair in this area, if it's protruding outside, it should give you a suspicion of a dermoid with sinus. And this sinus tract, if you follow it, it can lead to the dermoid cyst, and this type of dermoid cyst lies behind the nasal bone. It lies under the nasal bone, in front of the nasal septum, or it can go very deep. It can have an intracranial dural connection also. Is this clear to all of you? A simple dermoid lies outside the nasal bones. A dermoid with a sinus will have an external communication. And second point, it lies inside, behind the nasal bones. Is that clear? Okay. Lies behind nasal bones. Now, if it has, I told you, it could just lie under the nasal bones, or it could go as deep, very much deep into the cranium and have an intracranial dural connection. If it has an intracranial extension, this sinus tract will pass through the cribriform plate. Of course, that is the intervening structure in between. So, it passes through the cribriform plate, or sometimes it can even go via the foramen cecum, and then it is attached to the dura mater in the cranium. Is that clear? There will be a sinus tract. It can have intracranial extensions. If it has intracranial extensions, it can pass via the cribriform plate or by the foramen cecum. Is that clear? Now, how do we treat this condition? We have to do a surgery, split the nasal bones sometimes and remove the extension. We have to track the sinus, go deep into it and remove everything. First of all, why should it be treated? Because infections can travel along the path. It can lead to meningitis also. Fine. It's usually a neurosurgical plus an ENT approach that's required to remove this. But removal is important. The entire fistulous tract has to be removed. After dermoid cyst, next in this list is an encephalocele or meningoencephalocele. What is encephalocele or meningoencephalocele? It is herniation of the brain tissue via a congenital bony defect. Encephalocele is herniation of brain tissue. How will it herniate? Through a congenital defect. Congenital bony defect. Now, if both brain tissue plus meninges herniate, we call it meningoencephalocele. Is that clear? Now, there are various types among this meningoencephalocele. It could present in the midline at the root of the nose, or on the side of the nose, or on the anteromedial aspect of the orbit. It could be a naso-orbital variety, naso-ethmoidal variety if it's on the side, or a nasofrontal variety if it is at the root of the nose. Like that, depending upon where it is coming out, we have various presentation. How will it present? It will present like a subcutaneous pulsatile swelling. It presents as a subcutaneous pulsatile swelling. What are the various types of presentations? Nasofrontal variety, if it is at the root of the nose. Nasoethmoidal variety, if it is at the side of the nose. Nasoorbital variety, if it occurs on the anteromedial aspect of orbit. So it is a pulsatile swelling and it can show cuff impulse and it could be reducible also. How you have to treat it? Neurosurgically, remove the stalk from the brain and repair the bony defect so that it doesn't herniate again. That is the treatment. Surgery, where the stalk is removed and defect is repaired. This is about a meningoencephalocele or an encephalocele. And finally, last in this category is a glioma. What is a glioma? Now, glioma also to begin with starts like an encephalocele only, but somewhere during the embryonic development, the stalk is nipped off. Okay, so this now appears as an isolated, separate swelling. The nipped off portion of encephalocele is a glioma. Mostly they are extranasal and they also present as subcutaneous swellings on the bridge of the nose or side of the nose or at the inner canthus, like that at various locations. Some of them they are only intranasal, they are totally inside the nose, and very few they could be both intranasal and extranasal. Extranasal ones, they are easy to remove. Okay, that's the reason I'm telling you about this classification. If it's extranasal, you can easily remove them off. So what is a glioma? It is a nipped off portion of encephalocele. Somewhere during embryonic development, it gets nipped off. And this could be extranasal, intranasal, or sometimes both intra as well as extranasal, and you have to remove them. That is the treatment. Now, benign tumors arise from the nasal skin. You can have hemangiomas, you can have papillomas, you can have neurofibromas, tumors of sweat glands, seborrheic keratosis, pigmented nevus, all the various types of skin tumors that are possible elsewhere in the body are possible in the nose also. These are the various benign tumors. But let us specifically discuss about a few conditions. First among them is rhinophyma or a potato tumor. It's an important short question. Rhinophyma or potato tumor. This is a slow growing benign tumor. Why does this occur first of all, and what exactly is it? It is hypertrophy of the sebaceous glands of the nose. You must remember this condition exactly. It is hypertrophy, meaning enlargement in size, not hyperplasia. When you are answering multiple choice questions, sometimes to confuse you in the exam, they will give hyperplasia of sebaceous glands. It is not hyperplasia, it is hypertrophy. Okay, just enlargement. This is a benign condition. Please remember, the cells are only enlarging. So, hypertrophy of the sebaceous glands on the tip of the nose. This is a very slow growing tumor. It will take many years, okay, but the problem with it is initially it's very small and the patient also ignores it, but later after many decades it can become very huge, so huge that it can even distort the vision. And of course, cosmetically, the patient will definitely have a huge problem because it appears like a potato in front of the nose, and it can also lead to nasal obstruction. So the patient will want to get rid of it, although it is a benign tumor. And upon examination, how does it look? It looks like a pink lobulated mass. Pink lobulated mass. And on that there is superficial vascular dilation. Middle-aged people are usually affected with it, and it's usually men who are affected more commonly than women. So the patient will come to you because of any of these problems. Mostly, first to begin with, it's it has an ugly appearance on the nose. I told you, external nose, any deformity, it's a matter of concern to the patient. And secondly, the patient can have nasal obstruction, and the patient can have vision problems when it becomes very large. So what you have to do while treating, we have to first debulk the tumor. You can use a sharp knife or you can use a carbon dioxide laser. Just debulk the tumor and then allow re-epithelialization. Sometimes you can completely excise the tumor also if it is quite small, and you can leave the raw area with some skin graft. So this is about rhinophyma or potato tumor, that is very important to the nose. Papilloma, hemangioma and all those things I need not discuss. There is nothing very specific about them, nose per se. Okay. So let's move on to the next category, and that is malignant tumors. Under malignant tumors, we just have three of them, very predictable. First is basal cell carcinoma, next is squamous cell carcinoma, and finally a malignant melanoma. Let's discuss about basal cell carcinoma first. Among these three, basal cell carcinoma is the most common one. It is the most common malignant tumor involving the nose. It affects males and females equally. Again, middle-aged, middle to upper age group, around 40 to 60 years. What you will see is on the tip of the nose or on the ala of the nose, it first begins. Now, this is also called as a rodent ulcer. Basal cell carcinoma is also called as rodent ulcer. It will initially present as a small cyst or a papulopearly nodule or an ulcer with rolled edges. Now this presentation you must remember, and you must also be able to identify if a picture is shown to you. Either a cyst or a papulopearly nodule, or, this is important, ulcer with rolled edges. This ulcer with rolled edges means the examiner is trying to give you a hint that it is basal cell carcinoma. Now this is a very slow growing tumor. It will take years to grow to the size of a sizable tumor. and it remains confined to the skin only for a long time. It does not even invade the cartilage or the bone. Nodal metastasis onto lymph nodes is extremely rare. I can say there is no metastasis also. So it's a good tumor, it's very slow growing, no metastasis, it doesn't invade the surrounding structures, it's mostly confined to the skin. So this is about basal cell carcinoma. How will you treat depends upon the size, location and depth of the tumor. Of course, ultimate treatment is it has to be removed. How will you remove? Either you can do irradiation or cryosurgery and remove. But the problem is, if it is a recurrent basal cell carcinoma, or if it is very extensive, or if it has invaded into the cartilage or bone, then a major surgery has to be done and the defect has to be closed by using some flaps or prosthesis. So I hope basal cell carcinoma is clear to you. Next we have squamous cell carcinoma. Squamous cell carcinoma is second most common after basal cell carcinoma. Now this squamous cell carcinoma is also known as epithelioma. This also affects both males and females equally and the age group is 40 to 60. This occurs as an infiltrating nodule. It occurs as an infiltrating nodule. Or the presentation is an ulcer with rolled out edges. Here nodal metastasis is seen. Metastasis occurs. Not very common, but it does occur. In basal cell carcinoma, it's almost nil. Here there is a 20% chance. Early lesions, you can give radiotherapy if it's quite advanced or if it has invaded into bone or cartilage. Then a wide surgical excision and plastic repair of the defect has to be done. If at all lymph nodes are already involved, we have to do a block dissection for them. Last among this list is a melanoma. It is the least common variety. Clinically, what you see is it is superficially spreading type. Slow growing, superficially spreading. Or it can be nodular invasive type also. And how will you treat this? By surgical excision. Now please understand that melanoma of the nose is quite rare. It's the least common among all the varieties, all the tumors, okay? So with this, I complete all the disorders of external nose. Let me very quickly brush them up for you again. So first we have deformities. Under deformities, congenital and acquired mostly because of trauma. So we can learn them under two headings, midline deformities and lateral nasal deformities, and finally one more variety, stenosis and atresia of the nares. So in midline, we have saddle nose, we have hump nose, and we also have various types of tip deformities. Under lateral nose, we have crooked nose, deviated nose, and also alar depression. Under stenosis and atresia of the nares, a web formation can occur either post-trauma or post-surgery, or sometimes very rarely congenital atresia can also occur. Next, we have inflammatory disorders, important among them vestibulitis, first one. What all do you know about vestibulitis? It is diffuse dermatitis. It is diffuse dermatitis and it occurs in persistent infected nasal discharge, nose picking and repeated cleaning with a handkerchief. And causative organism is Staph aureus. And what are the clinical features? Very predictable, all signs of inflammation will be there. What you have to remember is in chronic conditions, induration of the nose, induration of the vestibular skin is a cardinal feature. And treatment is by cleaning, antibiotics and steroid treatment, and you have to treat the cause, that is most important. Next we have furunculosis, which is infection of the hair follicle, and etiology includes trauma and plucking of the nose. Causative organism is Staph aureus. It usually occurs in immunocompromised individuals. All signs of inflammation will be there, and treatment same, pain relief, warm compression and analgesics, and antibiotics, incision and drainage if necessary. It can complicate into a cavernous sinus thrombosis or a septal abscess if it is not properly treated, and mostly if it is pinching of the furuncle if at all done. It should never be done, and you should in fact advise the patient not to meddle with the furuncle. Okay? Yes. Next we have cellulitis, which is just nasal skin infection by streptococcus or staphylococcus, and treatment, analgesics and antibacterials. Erysipelas is one step more than cellulitis. There is acute spreading cellulitis that has come onto the face also from the nasal vestibule. So fever, lymphadenopathy will be there, and all signs of inflammation in the vestibular area. This can also complicate into cavernous sinus thrombosis. Neoplastic, we have congenital. In congenital, we have dermoid, a simple dermoid, and also a dermoid with a sinus. Then we have encephalocele or meningoencephalocele, which is herniation of the brain tissue from a congenital bony defect. And then we have glioma, which is encephalocele only, but it has been nipped off. So there is no connection to the brain tissue. And benign tumors and malignant tumors. Under benign tumors, there are various varieties, but what you must know is a rhinophyma, potato tumor, potato nose, it's also called. Malignant tumors are basal cell carcinoma, squamous cell carcinoma, and melanoma. Is that clear to all of you? So, basal cell carcinoma is most common, second most common is squamous cell, and melanoma is very, very rare. These are all the disorders of external nose. It's quite a simple topic. If you listen to it once, you're almost done. You can remember it till the exam. So that's about external disorders. Thank you very much and have a nice day.